I'm Kieran Anderson, group publisher here at Applied Radiology, and we're here live at RSNA. I've got the pleasure of being joined today by Dr. Susie Bash, who is a neuroradiologist, medical director at RadNet, and also the chief medical officer at Cortex AI. Is that correct?
That's correct. Thanks for having me, Kieran.
Oh, it's truly a pleasure. And we're also joined by Dr. Jeff Rudy, who is a neuroradiologist at Scripps and also an associate professor at UCSD. Is that right?
That's right, yeah. Thanks
Excellent.
for having me.
Yeah, happy to have you both here. And we're going to talk a little bit about neuroquant for brain tumors. And, I'm fascinated to hear what you really have to say, because I'll start with you, Dr. Bash, but what are some of the, kind of key indications for neuroquant brain tumor?
Yes, so a neuroquant brain tumor is an FDA-cleared product that allows us to assess the volumes and segment areas of brain tumors. So it's really useful technology. Basically, it will calculate the volume of enhancing tissue in a tumor, as well as the surrounding zone of flare hyperintensity. Really, the product started out, the algorithm was developed for GBMs, high-grade gliomas, and also low-grade gliomas. And so that flare hyperintensity could be the surrounding zone of edema, or it could be low-grade infiltration into the adjacent soft tissues. But the software does a great job of separating that from the enhancing tissue. It will also calculate the volume of the central necrotic core, if it's present, and then in post-op cases, also the resection cavity. And then it will allow you to longitudinally plot over time those individual components, such as the enhancing nodular tissue and the overall lesion size. So in the post-op cases, it will subtract out the resection cavity and allow you to plot that over time. So it's an extremely useful tool for following brain tumors. Now, right now, we started again with gliomas, but in the future, it will be applied also for meningiomas and metastases. So that's a really exciting development for the product, because meningiomas are a dime a dozen for us as neuroradiologists. We see them every day, and it turns out that we're not that great at measuring due to differences in slice sampling and head angulation, and we're only just doing sort of a three-dimensional measurement on imaging, and then we actually have to remeasure on the prior study, because we don't know where our colleague basically placed the calipers when they measured the prior. It's time-consuming for us, and frankly, computers do a much better job at it.
No, it's a really, really good point. And, Dr. Rudy, when you think about sort of the inputs and outputs of, a tool like this, and really like how these tools are modeled, like how was the model trained? What would you say about that?
So I should say that I'm also actually part of the International Brain Tumor Segmentation Challenge. So I've been on the research side. I've been working with people and different research societies on how to do brain tumor segmentation. So as part of Cortex, we kind of aligned the research world with this clinical product to be used in clinical practice. So what has been done previously in the research and what is part of this product is that there's actually 4 sequences that are used as input into the model. So T1 pre-contrast, T1 post-contrast, T2 and flare, and this is in contrast to some of the other neuroquant products, which usually use either a T1 or a flare. So for brain tumor imaging is much more complicated, and so you have to have all those sequences to provide to be able to predict and segment the different tissue regions from the brain tumor. So T1 post-contrast obviously is the most important for identifying areas of enhancement, but you need a T1 pre-contrast to identify areas of hemorrhage intrinsic T1 hyperintensity to distinguish what's just hemorrhage versus actually enhancing tumor. The flare is going to be your most sensitive sequence for identifying tumor infiltration, edema. And the T2 actually, interestingly, while it's not as useful in preoperative brain tumors, it's quite useful in the postoperative setting. T2 it really helps you identify resection cavities from areas of necrosis. It also is useful in trying to distinguish kind of infiltrating areas of tumor. So those are your 4 kind of standard inputs. And in this case, the product was FDA cleared for both pre and post-treatment, so pre-surgery as well as post-treatment after all surgery, resection, radiation, all of that. And it is also cleared for both low-grade gliomas and high-grade gliomas. So those are your kind of inputs. You need those 4 sequences, which are pretty much standardly acquired on brain tumor protocols and most brain any sort of brain MRI. Typically, you get those 4 sequences. So those go in. We have about 700 cases from about 20 different institutions that are used to train the model, and as with most tools these days, it's using a convolutional neural network. So using the NNUNet convolutional neural network has kind of been established as like the leader of a variety of different biomedical image challenge segmentations, just has the best performance. So you're training with NNUNet, and then as Susie mentioned, kind of you have these 4 standard outputs. You have the segmentation map, the volumes of what's the enhancing tumor, what's the central area of necrosis, the resection cavity, if there's a resection cavity, and then the surrounding flare hyperintensity. So those are outputted by the model, and you'll get in your packs, you'll get basically an overlay of the original T1 post-contrast image plus all these segmentation maps. You can see where the segmentations are. That's the first kind of DICOM overlay you see, and then you get your PDF report, which will show you the longitudinal aspects of it. If it's the volumes over time, and we're focusing on the kind of 2 important ones, which would be the volume of enhancing tissue and then the total tumor volume. So you can see those tracked over time and get like percentages of its increase, decrease, change compared to all the time points and track it over time. The other thing that's actually quite useful is oftentimes patients are getting treated with radiation, and the radiation oncologists need to be able to target where they're going to be giving their radiation. So in addition, the software will output a RT struct file, which allows it to be imported into radiation planning softwares, so radiation oncologists can use that directly for radiation treatment. So that's kind of the summary of like the inputs and outputs of the current product.
And one other thing I was going to add also to what Jeff said is, you know, in high-grade gliomas, for patients that have been treated, so they're resected or wherever, they obviously have a high chance of recurrence. But often on imaging, it is impossible to tell whether it's pseudotumor progression when you have enhancing nodular tissue around the resection cavity, or whether that's true progression of disease. And one really exciting component of the NeuroQuant brain tumor, it has an RSI module, which stands for restricted spectrum imaging. And it's sort of like a high-level advanced diffusion technology that allows you to see in a color-coded way. It can help you differentiate between pseudoprogression and true progression, which would be hot in appearance on the RSI. So it's a really interesting tool that can be utilized as well.
I would imagine that this can impact patient outcomes. You mentioned treatment planning, clinical decision. How is this, how is all of that making a difference, say, with the neuro-oncologists?
Well, I can tell you that the neuro-oncologists that I've talked to are really excited about this technology because, again, just having accurate segmentation and being able to longitudinally plot that over time, and then with the added bonus of potentially being able to tell the difference between pseudoprogression and true progression, it's a very, very useful tool. And again, in the near future, moving out of just gliomas and into other kinds of brain tumors, meningiomas, and metastases, it can make the difference. It really can make the difference in a patient's life. You want to identify the lesions as, like in metastases, they start at like 1 millimeter in size. To be able to use automated software to detect the metastases if you start treatment earlier, you can absolutely impact morbidity and mortality. So again, I see this kind of tool as becoming standard of care in the future. It's labor intensive to measure, and the software does a better job at it, at the volumetrics. And truthfully, volumetrics is much better than three plane measurements by us manually. What you might see as just minimal increase volumetrically might actually be a large amount of increase. And so again, very useful tool.
I'm guessing you'd agree with that.
Oh yeah, absolutely, yeah. To go a little more into the RSI, so actually at UCSD, I just had a paper that was published on RSI and trying to take it to the next step. So the RSI maps are really nice because they do kind of pop out areas of restricted diffusion that having to do with like cell bodies, that spherically restricted diffusion. But what we did is we took the next step in this research project, which I hope to be work on in developing in the next part of NeuroQuant brain tumor. But we took those RSI maps, combined them with the traditional T1 pre-post flare, and created a separate model that combines the diffusion information, and also by perfusion and traditional imaging to really more precisely identify areas of cellular tumor. So the progression versus pseudoprogression, and also infiltrating tumor. The RSI on its own is useful, but it actually combining it with all the other sequences in its own deep learning model is showed to be even more effective.
Do you consider that a future development, or is that something that you're working on now? Because I was just curious to know, like, what kind of enhancements are planned for NeuroQuant brain tumor?
Yeah, so the first thing I can tell you is even though I tend to think that the 3D volumetric measurements are going to be more accurate, that the standard in the field for RANO response assessment in neuro-oncology is in fact 2D measurements, biplane measurements, and that's what's used in clinical trials. And that's kind of what is the standard of care, despite the fact that 3D volumetric probably is better. So we are, one of the first things that's going to be, it's been in progress and should be deployed soon is automated RANO measurements.
Mm-hmm.
That's beginning early next year, and then as Susie mentioned, expanding to meningiomas and metastases are kind of the big next steps for next year. And again, yeah, meningiomas are the most common CNS neoplasms all the time. It's a very common indication for exam. Gliomas are less common. I mean, more at larger academic centers, but meningioma would be big to have that at automatic volumetric assessment. And metastases, especially at places that are treating patients for metastases with radiosurgery, you have to be the same sort of thing. They have to look at the images, and if there's a patient with 20, 30 brain metastases, they have to manually draw each of those brain metastases. Both the radiologists for their radiology reports, and then the radiation oncologists need to actually draw them so they can actually target them. So expanding to those two things are kind of two main kind of next steps. Yeah.
And Jeff has been, by the way, instrumental in helping develop this technology. He's really made a big difference in the neuro-oncology, really globally. And Cortex has the advantage of using his knowledge and to help, develop this algorithm. But again, not all tumors are the same. Like some of these meningiomas, like skull-based meningiomas, they grow into all kinds of planes. I look at this tumor and I don't even know where to place the calipers because it's so irregular shaped and it's extending along different areas. And again, back to this, volume, the volume is just so much of a more accurate way to measure the tumors. So I think everyone will be using this in the future, and we're just trying to get the word out there that this software is available.
Well, I want to say thank you on behalf of all of us here at Applied Radiology for you two taking the time to sit down with us. Really, I appreciate you telling us a little bit more about NeuroQuant for brain tumors, how you're using it, the difference it's making in your practices with your patients. Thank you both, Jeff and Susie. Thank you.
Thanks for having us, Kieran.
It's our pleasure.